Hello everyone, and welcome to another chapter for Advanced Pharmacology. Today here in Unit 20, Drugs for Eyes, Ears, and Skin, we're talking about Chapter 84, Drugs for the Eye. The drugs addressed in this chapter are used to help diagnose and treat disorders of the eye. Our primary focus will be on glaucoma. Many of the drugs considered here are discussed in other chapters, so the discussion in this chapter is limited to ophthalmologic applications. So, drugs for glaucoma. Glaucoma refers to a group of diseases characterized by a decrease in peripheral vision secondary to the optic nerve damage. The most common forms of glaucoma are primary open-angle glaucoma and acute angle closure glaucoma. These forms differ with respect to the underlying pathology as well as their treatment. In the US, glaucoma is a leading cause of preventable blindness. Of about 120,000 Americans blinded each year by glaucoma, 90% could have saved their sight with timely treatment. Unfortunately, many afflicted people are unaware of their condition. Of the 4 million Americans with glaucoma, only about 50% are diagnosed. So, before discussing glaucoma, we need to review the role of aqueous humor in maintaining intraocular pressure. As shown in the following figure, aqueous humor is produced by the ciliary body and secreted into the posterior chamber of the eye. From there, it circulates around the iris and into the anterior chamber, and then exits the anterior chamber through the trabecular meshwork and canal of Schlemm. If outflow of the anterior chamber is impeded, back pressure will develop, and IOP, or intraocular pressure, will rise. Conversely, if the production of aqueous humor starts to fall, IOP will decline. So, the pathophysiology and treatment overview, specifically on patient education on glaucoma. It is important to take the prescribed medication according to the schedule. If days are skipped or if prescriptions are not refilled, loss of vision may occur. Notify the provider immediately if experiencing vision loss, severe eye pain, headache, or nausea and vomiting, as these could indicate an angle closure glaucoma. If photophobia is a problem, when outdoors, sunglasses, wide-brimmed hats, visors, or baseball caps may be helpful. And finally, check labels of ophthalmic drugs to see if they contain benzalkonium as a preservative. These drugs may be absorbed by soft contact lenses. Allow at least 15 minutes to elapse between administration and the insertion of the lens. So, we'll start off by talking about the primary open-angle glaucoma. So, its characteristics. Primary open-angle glaucoma, or POAG, is the most common form of glaucoma in the US. About 90% of people with glaucoma have this type. POAG is the leading cause of blindness in the US. POAG is characterized by progressive optic nerve damage with eventual impairment of vision. Visual loss develops first in the peripheral visual field. As the disease advances, loss occurs in the central visual field. The pathologic process that leads to optic nerve damage is not understood. IOP is often elevated, but it may also be normal. POG is a painless, insidious disease in which injury develops over years. Symptoms are absent until extensive optic nerve damage has been produced. So what are the risk factors then? Well, the major risk factors for POAG are elevated IOP, or intraocular pressure, African or South American ancestry, family history of POAG, and advancing age. Of these, elevated IOP is most important. Please note, however, that glaucomatous optic nerve damage can develop even when the IOP is normal. Furthermore, some individuals can have a very high IOP, with no associated injury to the optic nerve. These individuals are said to have ocular hypertension and not glaucoma. So, screening. Because POAG has no symptoms, regular testing for early POG is important among individuals at high risk. With early detection and treatment, blindness can be prevented. Its management. Treatment of POAG is directed at reducing elevated intraocular pressure, the only risk factor we can modify. Although POAG has no cure, the reduction of IOP can slow or even stop disease progression. Management is usually initiated by specialists. However, primary care providers often play a role in ongoing monitoring and follow-up of patients taking these medications. The principal method for reducing IOP is chronic therapy with drugs. Drugs lower IOP by either facilitating aqueous humor outflow or reducing aqueous humor production. So, as indicated in the following table, the first-line drugs for glaucoma belong to three classes: beta-adrenergic blocking agents, alpha-2 adrenergic agonists, and prostaglandin analogs. Other options, such as cholinergic drugs and carbonic anhydrase inhibitors, are considered second-line choices. All of the anti-glaucoma drugs are available for topical administration, which is the preferred route. For more than 25 years, the beta blockers have been considered drugs of first choice. However, the alpha-2 agonists and prostaglandin analogs are just as effective as the beta blockers and have more desirable side effects profiles. Accordingly, these drugs have joined the beta blockers as first choice agents. Because drugs in different classes lower IOP by different mechanisms, combined therapy can be more effective than monotherapy. Because all of these drugs are applied topically, systemic effects are relatively uncommon. Nonetheless, serious systemic reactions may occur if sufficient absorption takes place. So here is an excellent spot to hit pause so you can see all the topical drugs for open-angle glaucoma. Whether it's a beta blocker, a prostaglandin analog, an alpha-2 adrenergic agonist, or some of the second-line agents such as the cholinergic drugs or carbonic anhydrase inhibitors. If drugs aren't able to reduce IOP to an acceptable level, surgical intervention to promote outflow of aqueous humor may be indicated. Options include a trabeculectomy or a laser trabeculoplasty. Which now brings us to angle closure glaucoma. Angle closure glaucoma is precipitated by the displacement of the iris, such that it covers the trabecular meshwork, thereby preventing exit of aqueous humor from the anterior chamber. As a result, IOP increases rapidly and to dangerous levels. This disorder is referred to as an angle closure or narrow angle glaucoma because the angle between the cornea and the iris is greatly reduced. Angle closure glaucoma develops suddenly and is extremely painful. In the absence of treatment, irreversible loss of vision occurs in 1 to 2 days. This disorder is much less common than the open-angle glaucoma. So here is a picture version of the comparative anatomy of the eye. Treatment consists of drug therapy, followed by the corrective surgery. A combination of drugs is employed to suppress symptoms. After IOP has been reduced with drugs, definitive treatment can be rendered with surgery. Options include iridectomy and laser iridectomy. Both procedures may alter the iris to permit unimpeded outflow of aqueous humor. So, what kind of drugs can we use to treat glaucoma then? Well, starting off with the beta-adrenergic blocking agents. Actions and use in glaucoma. The 5 beta blockers, betaxolol, carteolol, levobunolol, metipranolol, and timolol, are approved for the use in glaucoma. Dosing is topical, and these agents cause minimal disturbances of vision and are considered the first-line drugs for glaucoma. Although prostaglandin analogs are becoming favored, formulation and dosage of the beta blockers are shown in the following table. The beta-adrenergic blockers lower intraocular pressure by decreasing the production of aqueous humor. Reductions in IOP occur with a non-selective beta blocker, as well as with a cardioselective beta blockers. Beta blockers are used primarily for open-angle glaucoma. They are suitable for the initiation therapy as well as for maintenance therapy. Beta blockers in combination with other drugs are also employed for emergency management of acute angle closure glaucoma. The basic pharmacology of beta blockers was already discussed in chapter 14. So there are some adverse effects. Local adverse effects include conjunctivitis, blurred vision, photophobia, and dry eyes. Local effects are generally minimal, although some patients do have complaints of a transient ocular stinging. The systemic adverse effects. Beta blockers can be absorbed in amounts sufficient to cause systemic effects. Instilling just one drop of 0.5% of timolol in each eye can produce the same blood level as taking a 10 mg of timolol by mouth. Effects on the heart and lungs are the greatest concern. Blockade of cardiac beta-1 receptors may produce bradycardia and atrioventricular heart block. Pulse rate should be monitored. Because of their ability to depress the cardiac function, beta blockers are contraindicated for a patient with AV heart block, sinus bradycardia, and cardiogenic shock. In addition, they should be used with caution in patients who have heart failure. Blockade of beta-2 receptors in the lungs may cause bronchospasms. Constriction of the bronchi can occur with a beta-1 selective antagonist, as well as with a non-selective beta-adrenergic blocker. Although the risk is greatest with the non-selective agents, only one ophthalmic beta blocker, betoxolol, is a beta-1 selective. This drug is preferred to other beta blockers for patients with asthma or chronic obstructive pulmonary disease. Our prostaglandin analogs. There are 4 prostaglandin analogs that are approved for the topical therapy of glaucoma. These drugs are as effective as beta blockers and may cause fewer side effects. Accordingly, they are considered first-line medications for glaucoma. So the following formulations and dosages are shown in this table. A good spot to hit pause so you can take a look at all the different medications. The first medicine that we'll talk about, however, is latanoprost, also known as Salitan, which is an analog of the prostaglandin F2 alpha, which was the first prostaglandin approved for glaucoma and will serve as the prototype for the group. The drug is applied topically to lower IOP in patients with open-angle glaucoma and ocular hypertension. Latanoprost lowers IOP by facilitating aqueous humor outflow, in part by relaxing the ciliary muscle. The recommended dosage is 1 drop, applied once daily in the evening. At this dose, latanoprost produces the same reduction in IOP as does timolol twice daily. So here is a good spot to hit pause so you can see the prototype drugs for all the different types of medications, but we will be discussing each of these in turn. Latanoprost is generally well tolerated, and systemic reactions are rare. The most significant side effect is a harmless heightened brown pigmentation of the iris, which is most noticeable in patients whose irides are green-brown or yellow-brown or blue-gray-brown. The effect is rare in patients whose irises are blue, green, or blue-green. Heightened pigmentation stops progression when latanoprost is discontinued, but does not usually regress. Topical latanoprost may also increase pigmentation of the eyelid and may increase the length, thickness, and pigmentation of the eyelashes. Other side effects include blurred vision, burning, stinging, conjunctival hyperemia, and punctate keratopathy. Rarely, latanoprost may cause a migraine. So, other prostaglandin analogs. In addition to latanoprost, three other topical prostaglandins are approved for topical therapy for glaucoma. Similar to latanoprost, these drugs, travoprost, bimatoprost, and tafloprost, reduce intraocular pressure by increasing aqueous humor outflow. In clinical trials, these agents were at least as effective as timolol, a representative beta blocker. Interestingly, one drug, travoprost, was more effective in blacks than in non-blacks. Similar to latanoprost, these prostaglandins can cause the gradual increase in brown pigmentation of the iris, which again may be irreversible. In addition, these drugs can increase the pigmentation of the eyelid and the growth of the eyelashes. In fact, bimatoprost, marketed as Latisse, is used for the specific purpose of increasing eyelash length, darkness, and thickness. Without prostaglandins used to treat glaucoma, the most common adverse effect is ocular hyperemia, which is the engorgement of ocular blood vessels. Less commonly, these drugs cause blurred vision, eye discomfort, ocular pruritus, conjunctivitis, dry eye, light intolerance, and tearing. Which brings us now to the alpha 2 adrenergic agonists. Alpha 2 agonists are approved for glaucoma. One agent, aproclonidine, is used only for short-term therapy. Other agents, brimonidine has emerged as a first-line drug for long-term therapy, which is what we'll be talking about specifically. Brimonidine, also known as Alphagen P, is the first and only topical alpha-2 adrenergic agonist approved for long-term therapy in the reduction of elevated IOP in patients with open-angle glaucoma or ocular hypertension. Effects on IOP are similar to those achieved with timolol. The drug lowers IOP by reducing aqueous humor production and perhaps by increasing the outflow. In addition to lowering IOP, brimonidine may delay optic nerve degeneration and may protect retinal neurons from death. This possibility arises from the ability of alpha-2 agonists to protect neurons from injury caused by ischemia. The most common adverse effects are dry mouth, ocular hyperemia, local burning and stinging, headache, blurred vision, foreign body sensation, and ocular itching. In contrast to aproclonidine, brimonidine can cross the blood-brain barrier and hence can cause drowsiness, fatigue, and hypotension. Brimonidine can be absorbed also into soft contact lenses, so at least 15 minutes should elapse between the drug administration and the contact lens installation. Aproclonidine, or iopidine, is a topical alpha-2 adrenergic agonist that lowers IOP by reducing aqueous humor production and possibly by increasing outflow. The drug is indicated only for short-term therapy of open-angle glaucoma in a patient who have not responded adequately to maximal doses of other IOP-lowering drugs, and secondly, to preoperative medication before laser trabeculoplasty or iridodectomy. Side effects include headaches, dry mouth, dry nose, altered taste, conjunctivitis, lid reactions, pruritus, tearing, and blurred vision. Aproclonidine does not cross the blood-brain barrier and therefore does not promote hypotension. Alpha-2 agonist / beta blocker combo drugs. A fixed-dose combo drug of brimonidine and timolol is available for lowering IOP in patients with glaucoma or ocular hypertension. Benefits and adverse effects are about equal to those seen when the drug applied are separately. Formulations for dosages for the alpha-1 agonist and the alpha-2 agonist / beta blocker combo drug are shown in the following table. So make sure you hit pause so you can see the different medications as well as dosages and formulations. Which brings us to our next medication. Pilocarpine, a direct-acting muscarinic agonist. Pilocarpine is a direct-acting muscarinic agonist. Administration is strictly topical. The basic pharmacology of the muscarinic agonist is discussed in Chapter 12. Consideration here is strictly limited to the use in glaucoma. So, the effects on the eye. By stimulating cholinergic receptors in the eye, pilocarpine produces two direct effects: miosis and contraction of the ciliary muscle. IOP is lowered indirectly. In patients who have open-angle glaucoma, IOP is reduced because the tension generated by contracting the ciliary muscle promotes widening of the spaces within the trabecular meshwork, therefore facilitating outflow of aqueous humor. In angle closure glaucoma, contraction of the iris sphincter pulls the iris away from the pores of trabecular meshwork, thereby removing the impediment to aqueous humor outflow. Its therapeutic use. Although used widely in the past, pilocarpine is now considered a second-line drug for open-angle glaucoma. Pilocarpine can also be used for emergency treatment of acute angle closure glaucoma. Its adverse effects. The major side effects of pilocarpine concern the eye. Contraction of the ciliary muscle focuses the lens for near vision. Corrective lenses can provide partial compensation for this issue. Occasionally, sustained contraction of the ciliary muscle causes retinal detachment. Constriction of the pupil, caused by the contraction of the iris sphincter, may decrease visual acuity. Pilocarpine may also produce a local irritation, eye pain, and brow ache. Rarely, pilocarpine is absorbed in amounts sufficient to cause systemic effects. Stimulation of the muscarinic receptors throughout the body can produce a variety of responses, which would include bradycardia, bronchospasms, hypotension, urinary urgency, diarrhea, hypersalivation, and sweating. Caution should be exercised in patients with asthma or bradycardia. Systemic toxicity can be reversed with a muscarinic antagonist, which would be atropine. Pilocarpine is available in solution and a gel for topical use. Pilocarpine solutions have a relative short duration of action and must be administered more frequently than the gel. So the following table here has formulations and dosages. So it's always important and good to pause so you can see the different variety of options available. Ecothiophate, a cholinesterase inhibitor. Only one cholinesterase inhibitor, ecothiophate, is available for glaucoma. The drug has a long duration of action. The basic pharmacology of ecothiophate and other cholinesterase inhibitors was once again discussed in Chapter 12. Considerations here are limited to its use in glaucoma. So, if we're speaking strictly on the effects on the eye, cholinesterase inhibitors inhibit the breakdown of acetylcholine by cholinesterases, and thereby promote the accumulation of acetylcholine at muscarinic receptors. As a result, they can produce the same ocular effects as pilocarpine, which would be miosis, focusing of the lens for near vision, and the reduction of IOP. Its use therefore in glaucoma. Ecothiophate is indicated for POAG. However, because of concerns about adverse effects, the drug has not been considered a first choice agent. Rather, it's reserved for patients who haven't responded or have responded poorly to the preferred medications. Its adverse effects. Like pilocarpine, ecothiophate can cause myopia and excessive pupillary constriction. However, much of the greater concern is associated between the long-acting cholinesterase inhibitors and the development of cataracts. Absorption of ecothiophate into the systemic circulation can also produce typical parasympathomimetic responses, which include bradycardia, bronchospasms, sweating, salivation, urinary urgency, and diarrhea. So, its preparation, dosage, and administration, therefore. Ecothiophate iodide is supplied as a powder for the reconstitution to solution. Formulations and dosages are shown in Table 84.5. Carbonic anhydrase inhibitors, the topical. Dorzolamide, also known as Trusopt, was the first carbonic anhydrase inhibitor that is available for topical administration. The drug is used to reduce IOP in patients with open-angle glaucoma and ocular hypertension. Dorzolamide lowers IOP by decreasing production of aqueous humor. Responses are very similar to those that are produced by a beta blocker. Dorzolamide is generally well tolerated. The most common side effect is ocular stinging and a bitter taste immediately after dosing. Anywhere between 10 to 50% of patients experience allergic reactions, primarily conjunctivitis and lid reactions. If these do occur, the patient needs to stop dorzolamide and contact the prescriber. If other reactions include blurred vision, tearing, eye dryness, and photophobia occur. In contrast to systemic carbonic anhydrase inhibitors, dorzolamide does not produce acidosis or an electrolyte imbalance. Dorzolamide is available in a fixed-dose combo drug with timolol, marketed as Cosopt. The combo drug produces a greater reduction in IOP than either compound used alone. Furthermore, the dosage for these products are, as well as for other carbonic anhydrase inhibitors, are shown in the following list. So again, it's an excellent spot to hit pause so you can take a look at the different options available. Brinzolamide, or Azopt, is approved for topical treatment of elevated IOP in a patient with open-angle glaucoma or ocular hypertension. The drug is as effective as dorzolamide and better tolerated. Like other carbonic anhydrase inhibitors, brinzolamide reduces IOP by slowing production of aqueous humor. The most common adverse effects are bitter aftertaste and a transient blurred vision. Brinzolamide causes less ocular stinging and burning than dorzolamide. Both brinzolamide and dorzolamide contain the preservative benzalkonium chloride. This is absorbed by the soft contact lenses, so it's important that a patient who wears contacts wait at least 15 minutes after taking the medicine before putting in their contact lenses. Carbonic anhydrase inhibitors. Systemic. There are two carbonic anhydrase inhibitors, acetazolamide and methazolamide, which are available for systemic therapy of glaucoma. Acetazolamide is used more often. So how does it work in glaucoma? Carbonic anhydrase inhibitors lower IOP by decreasing the production of aqueous humor. Maximally effective doses reduce aqueous flow by up to 50%. Administration is considered oral. Carbonic anhydrase inhibitors are employed primarily for long-term treatment of open-angle glaucoma. They are not the first drugs of choice. Rather, they should be reserved again for a patient who has been refractory or preferred medications haven't been working. Carbonic anhydrase inhibitors may also be given to produce rapid lowering of IOP in a patient with angle closure glaucoma. Its adverse effects. Systemic carbonic anhydrase inhibitors can produce a variety of adverse effects. In the central nervous system, which are relatively common, they may include malaise, anorexia, fatigue, and paresthesias. The sense of malaise causes many patients to discontinue treatment. Reduced appetite coupled with a GI disturbance may result in weight loss. Carbonic anhydrase inhibitors are teratogenic in animals and should be avoided during pregnancy, especially the first trimester. Additional concerns are acid-base disturbances, electrolyte imbalances, and nephrolithiasis. So, prescribing and monitoring considerations for glaucoma. The therapeutic goal. The goal of glaucoma treatment is to prevent the progressive visual field loss and its acute symptoms through the reduction of IOP. Because POAG is often asymptomatic, primary care providers have important roles in identifying patients with risk factors. These patients are then screened for glaucoma through visual field testing, fundoscopy examination for optic nerve cupping, and tonometry to determine IOP if available. Definitive diagnosis and treatment decisions are typically carried out by the ophthalmologist. Primary care providers need to be prepared to monitor for outcomes or adverse effects that may indicate a need for a change in management. So, ongoing monitoring and interventions. Pharmacologic therapy for POAG is lifelong. Meanwhile, non-adherence to the medication regimen is considered extremely high. Various reasons for high rates of non-adherence have been proposed. These include the asymptomatic nature of the condition, frequent dosing intervals, and age-related issues. Age-related issues may include forgetfulness associated with dementia or failure of providers to continue medications when admitted to a tertiary facility. For these reasons, monitoring is especially important. Outcomes monitoring by the primary care provider may include fundoscopic examination and visual field testing. Monitoring of pharmacologic effects depends on the drug's prescriptions. Patients taking ophthalmic beta blockers will need to be assessed for systemic effects, which would include hypotension and bradycardia, AV blocks, and AVs due to bronchoconstriction. Prostaglandins have few adverse effects. They are expensive, however, and may create an adherence issue for patients who have a limited income. Patients taking alpha 2 agonists, brimonidine, should be assessed for CNS effects and hypotension. Verify that patients who wear soft contact lenses to allow at least 15 minutes to elapse between the administration of the lens insertion. Assessment of visual acuity can be important for patients taking the parasympathomimetics, pilocarpine, and echothiophate if changes are noted. Referral to an optometrist for new glasses may be in order. These patients should also be assessed for cholinergic effects. Finally, it's important to remember that a large number of patients will have an allergic response to the topical carbonic anhydrase inhibitors, uridozolamide. This will necessitate changing medications. Systemic drugs in this class may need to be discontinued if they cause significant CNS effects such as malaise. So, drugs for allergic conjunctivitis. Its pathophysiology. Allergic conjunctivitis, or AC, is defined as inflammation of the conjunctiva in response to an allergen. AC may be seasonal or perennial. Primary symptoms are itching, burning, and a thin, watery discharge. In addition, the conjunctiva are usually red and congested. Symptoms of AC result from a biphasic immune response. Initially, symptoms are caused by release of inflammatory mediators, histamine, prostaglandins, leukotrienes, and kinins from mast cells. The mediators stimulate mucus production, activate nerve endings, and promote vasodilation and increase capillary permeability. These symptoms peak about 20 minutes after allergen exposure and abate 20 minutes later. After this early response, symptoms typically reappear 6 or more hours later. The late phase is due to the recruitment of immune cells, your eosinophils, neutrophils, and macrophages, that amplify the inflammatory response. So here is a good spot to hit pause so you can see the drugs used to help manage allergic conjunctivitis. So I'll leave that up right here as it's a good spot to pause, and I'll keep going. AC can be managed by a variety of topical drugs. Mast cell stabilizers prevent release of inflammatory mediators. Patients should be informed that benefits take several days to develop and several weeks to become maximal. In contrast to mast cell stabilizers, histamine 1 H1 receptor antagonists can provide immediate symptomatic relief. Some drugs have two actions. They prevent mediator release from mast cells and they block H1 receptors. Ketorolac, a nonsteroidal anti-inflammatory drug, reduces symptoms by inhibiting cyclooxygenase, an enzyme required for the synthesis of prostaglandins. So here is another good spot to hit pause so you can see all the topical drugs for allergic conjunctivitis. Like the NSAIDs, glucocorticoids inhibit the production of prostaglandins. In addition, glucocorticoids inhibit the production of leukotrienes and thromboxane. So as a result, these drugs are highly effective. Because they have been associated with serious adverse effects, prescribing should be done by a specialist with the equipment to verify that symptoms are not caused by an underlying infection, such as herpes. Unfortunately, with prolonged use, they can cause serious adverse effects, which include cataract and eye infection, and the elevation of IOP. Accordingly, glucocorticoids are generally reserved for short-term therapy in a patient who did not respond adequately to safer drugs. The ocular decongestants decrease redness and edema by activating the alpha-1 adrenergic receptors on blood vessels, thereby causing vasoconstriction. Benefits are only symptomatic. These drugs do not interrupt any phase of the immune response. Furthermore, with regular use, rebound congestion is likely. For that reason, short-term use of no longer than 2 weeks is recommended. Fortunately, that gives time for the drugs, such as mast cell stabilizers, to become effective. So, prescribing and monitoring considerations, therefore. Well, it definitely needs an assessment of a therapeutic goal. The goal of treatment is to decrease the inflammation and discomfort associated with the allergic conjunctivitis. Early intervention may also decrease associated complications that occur secondary to dry eyes or vigorous eye rubbing. Before making a decision for therapy, it's important to determine the severity of symptoms. This can be used to guide treatment options. So, if there are mild symptoms, a mild pruritus that is intermittent or short-lived, whether there are moderate symptoms, mild to severe pruritus lasting a few days to 2 weeks without red eyiness, or eye redness rather, Severe symptoms, moderate to severe pruritus with eye redness. So here's a good spot to hit pause and you kind of see the management of allergic conjunctivitis in terms of a picture version breakdown. Identifying high-risk patients. The ocular decongestant are contraindicated for a patient with a history of angle closure glaucoma. Ongoing monitoring and interventions. Monitoring is needed to identify the success of interventions and the need to take therapy to a higher or lower level. Ideally, the least amount of drug necessary to control symptoms should be used for the shortest time necessary. If an ocular decongestant has been prescribed, these need to be discontinued after a couple of weeks. Failure to do so may result in rebound congestion. Most medications used to manage AC do not have significant adverse effects. The exception, however, is a glucocorticoid. Prescribing should be restricted to a specialist in eye care, such as an ophthalmologist. Because it can decrease immune responses, it's important to consider whether new symptoms may indicate an infection. If prescribed long-term, monitoring should include assessment for cataract development and the elevation of intraocular pressure. So, additional ophthalmic drugs. Drugs, for instance, for dry eyes. Ophthalmic demulcents, or also known as artificial tears, are isotonic solutions employed as substitutes for natural tears. Most preparations contain a polyvinyl alcohol, cellulose esters, or both. Artificial tears are indicated for relieving dry eye, syndromes, and discomfort and dryness caused by irritants, wind, and sun. In addition, demulcents may be used to lubricate artificial eyes. Artificial tears are devoid of adverse effects and therefore may be administered as often and as long as desired. Topical cyclosporin ophthalmic emulsion, or Restasis, is prescribed for dry eyes due to inflammation. It suppresses the immune response, thereby promoting the resumption of the tear production. Ocular decongestants, or decongestants. Ocular decongestants are weak solutions of adrenergic agonists applied topically to constrict dilated conjunctival blood vessels. These preparations are used to reduce redness of the eye caused by minor irritation. The adrenergic agents employed as decongestants are phenylephrine, nafazoline, oxymetazoline, and tetrahydrozoline. When applied in the eye in a low concentration found in a decongestant, adrenergic agonists rarely cause adverse effects. Local reactions, however, include stinging, burning, and reactive hyperemia, which may occur if the medication starts to get overused. The adrenergic agonists are discussed in Chapter 13, which takes us now back to glucocorticoids. Glucocorticoids are used for inflammatory disorders of the eye, uveitis, iritis, and conjunctivitis. Short-term therapy, in the absence of an infection, is generally devoid of any adverse effects. In contrast, prolonged therapy may cause cataracts, reduced visual acuity, and glaucoma. In addition, there is an increased risk for infection secondary to glucocorticoid-induced suppression of host defenses. The glucocorticoids are discussed in Chapter 56. Dyes. Fluorescein is a water-soluble dye that produces an intense green color. This agent is applied to the surface of the eye to detect lesions of the corneal epithelium. Intact areas of the cornea remain uncolored, whereas abrasions and other defects turn bright green. IV fluorescein is used to facilitate visualization of retinal blood vessels. IV fluorescein has been employed to help evaluate diabetic retinopathy and other abnormalities of the retinal vasculature. Fluorescein can also be used topically and intravenously to assess flow of aqueous humor. Adverse effects from systemic administration include nausea, vomiting, paresthesias, and pruritus. Severe reactions include anaphylaxis, pulmonary edema, and cardiac arrest, but they are considered extremely rare. Rose Bengal is applied topically to visualize abrasions of the corneal and conjunctival epithelium. Injured tissue appear rose-colored when viewed with a slit lamp. The dye is also employed for the diagnosis of dryness of conjunctival tissue. Lissamine green, another topical dye, turns bright green in the presence of conjunctival defects and dryness. Because it is less likely to cause stinging, it is beginning to replace rose bengal as a diagnostic tool. Topical drugs for ocular infections. Topical drugs are available for treating viral and bacterial infections of the eye. 4 antiviral drugs, difluridine, vidarabine, ganciclovir, and idoxuridine, are employed. The pharmacology of an antiviral drug is discussed in Chapter 78. Important antibacterial drugs are shown in Table 84.8. These drugs are used to treat serious ophthalmic infections and to prevent infection after ocular surgery. So as a rule, anti-infective drugs are not needed for simple conjunctivitis. Patients should be made aware that bacterial and viral infections are contagious. Bacterial infections will remain contagious until treated for 24 to 48 hours. Viral infections may remain contagious until they are completely gone. Patients should not use contact lenses while they have an eye infection and while they are treating an infection with a topical drug. And here are some topical ophthalmic antibacterial agents. So here's an excellent spot to hit pause one last time. I believe that does conclude our chapter here for today. I thank you as always for listening, and I'll see you at the next chapter.